So our first speaker for the afternoon is Dr. Andreas Charalambous. And Andreas is going to talk to us about palliative care, and that's learning from the past and looking to the future. So welcome, Andreas.
Thank you very much for the introduction, Teresa. It's a pleasure and privilege for me to be here all along with the rest of EONS board. And I would like to extend my thank you for the wonderful hosting we have been experiencing during the last 2 days. As Teresa said in the beginning, I am going to discuss a little bit about palliative care, one of the sexiest and most appealing topics within oncology and cancer nursing. At least that's my view on this. The way I thought that this would be interesting to do it is to step back and see where palliative care was and where palliative care is and where it should be in the future. So let's start with the definition of palliative care. I'm sure that if you go through the internet and the international organizations that deal with palliative care, you will manage to get much more definitions than this. But let's agree for the sake of this presentation that this is a working definition that we're going to be basing our presentation. So it is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. However, this definition was not, and it is not something that was there in this form forever. The main idea behind this definition is to promote the essence of palliative care. One of the essence of palliative care is to actually succeed in making people feel that they are not alone in this difficult journey they have to go through. And remember, we are all going to be taking that journey sooner or later. So the elements of compassion kicks in, or it should kick in when we are speaking about palliative care. So palliative care, if we want to speak in a more traditional terminology, it should affirm life, it should provide relief from pain, and most people stick to pain as the most prevalent symptom that occurs in cancer care and palliative care. However, pain has received much attention in comparison to other equally important symptoms that we shouldn't forget. Palliative care should integrate the psychological and spiritual aspects of patient care. And the literature shows that much less attention is paid to those dimensions of the human person. And that's sad. And palliative care should offer a support system to help the patients and their families to live as actively as possible throughout the end-of-life journey. So looking at the past, what do we see? Traditionally, palliative care was considered a monopoly for cancer patients. It was considered that only cancer patients should receive palliative care. Late referrals, when patients go into palliative care not on the right moment, then we have a negative impact in terms of the effectiveness of those palliative care programs. Because the later you go to palliative care, the later all the dimensions of the human person will receive attention, including psychological and spiritual caring, which are very, very important at this stage of the cancer care continuum. Still looking at the past, primarily palliative care and hospice services applies to those with cancer. And there is some sort of collusion of hope within those settings or before you go to those settings. But those collusion of hope can have significant implementation and complications during the bereavement period for the people that stay behind. And then there is limited or no specialized training, which is also an emerging theme within palliative care settings. So it is okay to look at the past. That's not the issue. The issue is not to stay on the past. You have to move forward. And the only way to go is forward in this case. So let's look again at the World Health Organization definition of palliative care. It's coming. You can see the green parts of this definition highlight all those things that have changed through the past. So, for example, it's not just about cancer. It includes all diseases that are life-threatening, degenerate diseases, for example, Alzheimer's, dementia. All these patients deserve and they should receive appropriate palliative care. And then the definition highlights a very important aspect, that this palliative care should start early at the diagnosis. And we're going to speak a lot more about that later in the presentation. So these palliative care interventions should not only be in place when there is no hope of cure, but it should coexist with traditional, more acute cancer care. So moving on from this definition, we can see what has changed, what has significantly changed with what the World Health Organization is talking about. It's obvious that no more we are not referring to a climate of healing. And we have moved to a more integrative palliative care, where acute and palliative care coexist within an integrative model of care. So when all hope of cure or disease control has been lost, is not the trigger to send somebody to palliative care. It shouldn't be. If that's the case, then you are probably too late. So within the traditional palliative care models and programs, we see that there is no comprehensive approach to meeting the needs and the expectations of both families and the patients themselves. So, and I'm sure if you do a Google search in terms of palliative care programs, probably this is going to show up. How many of you have you seen this before? Some, yeah. It came from Canada, actually, and it's very prominent within the palliative care setting. What we see here, and it's obvious, we see that palliative care increases as things in terms of the patient's situation are going to the worst. But there is a very prominent problem with this picture. What is the problem? What do you think is the problem with this picture, with this model of care? It's death. Not death by definition. We are all going to die eventually, and our patients will probably do as well. However, within these traditional models of palliative care, death has a central place. And that can be alarming to patients. So who wants to do or wants to receive care that the end point is always death? It's not appealing. On the contrary, it keeps patients away. And that is one of the problems of early palliative care referrals. And I'm not sure we have nothing to do with that problem or caring. So it's not inviting to patients and families. Hope, which it's a concept that much have been written about it, it's completely absent from that traditional model of care, completely. So is it forbidden? But there are many more challenges I can report in terms of high-quality palliative care. And I think it's worthwhile to discuss or even to report a few of those challenges. The demand for palliative care worldwide is increasing. It is estimated that about 20 million people are in need of some level of palliative care. And these numbers, unfortunately, will increase as the age of the people will increase. Integration of palliative care with acute oncology care. There's obviously many things that we don't know in that area. Colleagues from Sweden recently published a paper about working in silos. And that's true about palliative care. We have problems communicating between oncology and palliative care teams. I'm not saying that's the normal, but there is an issue there that needs to be acknowledged and addressed. There is a lack of golden standard. When do we integrate? When do we initiate palliative care? When do we stop palliative care? And there is obviously a lack of poor coordination of care. Perhaps a navigator nurse has a place in all of this. But if you are into research and you like hot topics, palliative care cannot get any hotter than this. So there is room for research there. There's a lot of hot going on, I know. So inequalities in terms of palliative care. Out of those 20 million people needing palliative care, around 18 million come from poorer countries. And what that translates into, it means that more and more people in those countries suffer without having to suffer. They have very little or no control over symptoms, and the list goes on. So they go through an end-of-life process that it's not pleasant, and it's not the way it should be. And the inequalities is not just between countries or between rich and poor. It's also between cancer patients and other life-threatening illnesses that I have reported earlier. There's even inequalities between cancer types themselves. It's pretty obvious that more popular cancer types such as breast cancer and prostate cancer receive more palliative care compared to other more rare cancers. And there are specific challenges as well. In terms, for example, patients with brain tumors, they are also facing challenges in terms of communications and cognitive behavior. So how do you communicate? How do you address spiritual and emotional needs in these patients? So those patients have extra challenges for the healthcare workers to address. And these are pretty obvious challenges one faces when in palliative care. Pain management. Pain is not just a physical symptom, but it can be an emotional, it can be a social, it can be a spiritual and an existential symptom. So the impact is much, much more than the body itself. Depression, almost 50% of our patients will face some sort of anxiety and depression throughout the cancer care continuum. And dignity, it's very important to think in palliative care settings. And dignity is not a simple term. It involves concepts such as autonomy and independence, respect and esteem. all those things are expressed by patients. It is one of the most significant fear expressed by patients, losing their independence. And we have to do something about it. And coping, we often get bad copers, people who respond negatively to the diagnosis and become defensive and become self-isolated. And we have to identify and address those things as well. So I am asking this question here, is change, having said all this, really necessary, or is just another presentation? So there should be something new out there that we could do about these patients, about these palliative care settings. So the first thing that we need to do, the thing that we need to adopt in our daily practice, it's a mind shift from the past to the present and the future. So we need a model, a different model than the normal ones, that has some sort of duality. On the one hand, you do acknowledge the difficulty of the situation, but you always leave room for hope and cure. But don't be mistaken. There is no panacea when we are speaking about palliative care. We cannot say this is right, this is wrong. There is no gray area either, no silver linings, nothing. So how should the future of palliative care look like? It should cultivate palliative care as a normal process and a process that is actually part of life. It should describe a process in which the possibility of dying can be gently introduced. Different patients require different handling, different management. It steps in at times when patients and their families' thoughts may be consumed by the notion of hope, the hope for cure. It should integrate psychological, spiritual, social, advanced care planning long before people even get sick. It should also include some complementary interventions, such as music, art therapy, physiotherapy, and much more. This is only a few to report. And how does this future look like? I won't say in an ideal world, but in a world of present. It should look like this. So moving from the traditional model, we move to this. So you see that the onset of palliative care, it happens at the start, at the beginning of the diagnosis. That's when you initiate palliative care for the patient. And as you move forward towards progression of illness, you may end up at complete cure, so you give hope, but you may end up at the worst case scenario, which is death. In both cases, palliative care adjusts its contribution to caring. So it complements, in a way, acute cancer care. And pain and symptom management, rehabilitation, hospice care, it all fits in this ideal environment. And survivorship, because as we go through time, more and more people will survive cancer, thankfully. On the same notion, we can see an adaptive patient pathway from the NICE guidelines. And we see that palliative care is not static. It shouldn't be static. It should come and go. It should be influenced largely and at some points less. So the future of palliative care, and I can't say this, is now. And we have power over the future. Not many times, not many issues and topics within cancer care we can have that much influence on. And partly it's because many of the things within palliative care are still unknown from the patient and the carer perspective. or the informal caregiver perspective. So with your actions, with your contribution, you have the power to achieve this, for the patient to feel and to stop counting the days and make those days count. Thank you very much. Thank you.
Thank you very much, Andreas. That was excellent. Have we got any questions for Andreas? There's just one here at the front. Go on, Patrick.
Thank you very much, Andreas. I have a question regarding to symptom management. There has been some research about symptom clusters.
Yeah.
Now it's coming back. Is that a topic that is especially to be explored in palliative care, and is it the case actually?
Well, symptom clusters, it all started in the US. It's okay. I think it's working. By Professor Miakowski. Actually, they published lots of papers about symptom clusters, which means that you have 2 or more symptoms occurring simultaneously, and those symptoms are somehow related to each other. However, maybe 15 or 20 years ago, a recent paper by the same people saying there is no such thing as symptom clusters. So that does it. So there is some sort of a gap in the literature in terms of symptom clustering and which symptom comes first. I wouldn't say that it is, I would say that it is transferable, the knowledge from acute oncology setting to the palliative care setting. But I think within the palliative care setting, it should be a shift in prioritizing the symptoms that occur. Was that your question? Thank you.
Thank you.
Thanks.
Any other questions for Andreas? No, thank you very much, Andreas.